So, welcome back again to the chapter 5 of your basic ECG interpretation. And for this chapter, we're going to discuss about junctional arrhythmias. So, by means of junctional arrhythmias, these are the problems that originates in the atrial junction. So that's the tissues that surrounds or just beneath the the AV node. Okay. So let's proceed with the first rhythm. Okay. So before we're going to take note of the junctional arrhythmias, please you need to consider that with junctional arrhythmias, it's either there is an absent P wave. Okay. So the hallmark characteristics of junctional arrhythmias is that there is an absent P wave or there is an inverted P wave. Okay. Sorry. So there's an absent P wave or an inverted P wave. Okay, so these are the signs, the hallmark characteristic of a junctional arrhythmias. Okay, so let's start with the first rhythm. So the rhythm, first of all, we need to know the heart rate. Okay, for us to determine if this rhythm is really related to junctional problems, because as what we have known is that SA node fires an impulses of 60 to 100. So here, so for us to determine that the one of the determinant factor that the impulses comes from the SA node is that the presence of your P wave and also the heart rate should be within 60 to 100. Okay, so in the absence of your P wave, or if the P wave is inverted and the rhythm is within 40 to 60, then possibly we are having a junctional rhythm or a junctional problem. Okay, so let's take note of this arrhythmia. So first we need to count the heart rate by counting the number of R waves. So we have 1, 2, 3, 4, 5, 6, 7, 8. So 8 times 10, we have a heart rate of 80. So this is actually a normal heart rate. Okay, so this is a normal heart rate. Then we need to know if we have a P wave. Okay, now let's check if we have a P wave. So P wave in this area is present, P wave is present, P wave is present. Also P wave is present, but this rhythm here, take note of this. This rhythm doesn't have a P wave, and then this rhythm has P wave, and this one has no P wave. So meaning that P wave is present in some rhythms, but there are rhythms that has no P wave. Okay, so let's check PR interval. PR interval on the rhythms that has P waves are normal since it is within one big box. Okay, so PR interval is normal only for those rhythm that has P wave. Okay, now let's check for the QRS complex. QRS complex are not narrowed. Okay, so they are normal. Let's check for T wave. For T wave, guys, we also have a T wave in each QRS complex. So every after QRS complex, there is a T wave, and also the ST segment is not elevated, also um, not depressed. So meaning we don't have any problem with ischemia or infarction with this rhythm, and there's no chest pain. Okay, so the only problem that we have is that there are these rhythms. Okay, so again, for us to know that the rhythm is junctional is that there is an absence of P wave or the presence of inverted P wave. Now let's check on these rhythms. Okay, so we have here, this one has no P wave because this one is actually a T wave. This is T wave, not P wave. This one also has no P wave. So meaning, guys, we have a normal sinus rhythm for this rhythm, but then we have a premature junctional rhythm or premature junctional contraction as represented by this one. Okay, so we have an NSR with PGC or normal sinus rhythm because we have a heart rate of 80, and also we have rhythms that are normal which has P wave, QRS complex, and T wave. But then there are some PJCs, which is your premature junctional contraction, as characterized by a QRS complex that has no P wave, that has absent P wave. Okay, so normally your PGCs are is a result actually of a overstimulation of your vagal nerve. Another one is that there's a problem with your sinus rhythm. I mean with your sinoatrial node, that it fails to fire on impulses, and then also extreme irritability of your junctional area. Uh, the irritability might be caused by an irritable focus or an area of hypoxia, especially if the idioventricular rhythm of your your IVC, or also known as your left descending left your IVCA, interventricular coronary artery, okay, which originates from the left coronary artery, actually has a CAD, or is having coronary artery disease, just like your atherosclerosis or arteriosclerosis. So this is the time that the area of the heart has an is experiencing hypoxia, causing the irritability of your junctional area, because your um, atrial junction is actually just is being supplied by your um, left ascending coronary artery, or your interventricular coronary artery. Okay, so if there is a problem here, then automatically this could be the result. Then one of the resulting factor also for this is problem with the automaticity. Okay, so this is what we call as junctional escape. Okay, so meaning your normal sinus, your SA node fires and impulses, but then um, due to automaticity or extreme irritability, your atrial junction also fires and impulses, and if the impulses was fired or triggered going to the ventricles, we call that one as antigrade, such as this one. This is an example of an antigrade because automatically it goes directly to the ventricle. So this is an antigrade rhythm. So just in case that the impulses or the triggered activity or the escape impulses travels back to the AV node, or travels back to the atria, then that is what we call as retrograde. Okay, so we will discuss more about retrograde and antigrade later on. Okay, so this rhythm does not require any medications at all, because your patient will not experience any problem. But if in case your patient is having this rhythm and also experiencing ischemia or chest pain, then you can manage chest pain, and it doesn't require any medication to treat this rhythm. But you can manage chest pain according to its severity. It could be through oxygenation, or giving medication that can alleviate pain. Okay, so let's proceed to the next rhythm. Now, for the next rhythm, let's check what's the heart rate of your patient. Now, counting the R wave, 1, 2, 3, 4, 5. So the heart rate of your patient is 50, since there are 5 R waves, and then multiply that one by 10. So we have a heart rhythm. Okay, so we have a heart rhythm of your patient, or the heart rate of your patient is 50. Now let's check for the P wave. Now, in these rhythms, guys, there are no P waves that can be found. So meaning there are no P waves. So this is the hallmark characteristic of a junctional arrhythmia. Okay. Now, since there's no P wave, then we also cannot determine the PR interval. Then we can check the QRS complex. Now, there are QRS complex here, meaning there is ventricular contraction. Okay. But there is no atrial contraction. Okay. While your T wave, there is still T wave, guys. Okay. So what happened with your junctional arrhythmias? Meaning, guys, that if your patient is having a junctional arrhythmia, this is what we call as your junctional arrhythmia. The rhythm is called junctional arrhythmia or junctional rhythm. Okay, so meaning your SA node also your SA node did not fire an impulse. Okay, there is a problem in the atrial area that the SA node did not fire an impulses, but instead it's the junctional or the atrial junction that fires an impulses as a compensation. Okay, so there could be there is something that happens in the atrial area wherein SA node is being affected. So it could be due to medication, adverse reaction of medication, and also one of that is your digoxin toxicity or overstimulation of your vagal nerve, of your vagus nerve, that causes the SA node to stop firing. Okay. Other problem is that due to degenerative diseases and any other diseases related to the to the atrial area. Okay, so take note that there is no atrial contraction during junctional rhythm, so make sure that you need to take note of the cardiac output of the patient, since as what we have known, or as what we have discussed earlier, there's only 75% that goes directly to the right ventricle, and also 90% will go directly to the left ventricle. And then there is a problem already that the atria um, cannot contract. So those 25% and 10% will not be pushed through the ventricles. So there's a lesser cardiac output for this. So you need to you need to um, monitor the patient for signs of dizziness and syncope. Also for difficulty breathing and cold clammy skin and poor oxygenation. Okay. Again, a rhythm that has no P wave or has inverted P wave, and also this fits the category of a junctional rhythm because junctional rhythm only fires 40 to 60 impulses, or the firing rate of your your atrial junction is only 40 to 60. So it means that this is a junctional rhythm. This one fits for a junctional rhythm. So any treatment for this, actually you need to treat the underlying cause for the underlying cause of this rhythm, so that um, it may subside, or we there be treatment if the patient is experiencing signs and symptoms. So you just need to manage it palliatively. Okay. So next rhythm. Okay. So next rhythm will be this one. So this one is a junctional rhythm. Then the next one we need to check the heart rate. Let's check the heart rate. 1, 2, 3, 4, 5, 6, 7, and 8. So we have a heart rate of 80. And then let's check if we have a P wave. Yes, we have a P wave, but it is inverted. So actually, this will fit the category of a junctional rhythm also. An inverted P wave or an absent P wave will automatically means that it is a junctional rhythm or a junctional arrhythmia. Then we can check for the QRS complex. The QRS complex, as you can see, it's normal. And then we can check the T wave. So T wave are present also. In most waves, T wave is present here. There are T waves, but there are waves that has no T waves. Okay, so T wave may be present in some rhythm or absent, present or absent in some rhythm. Okay, so how about your ST segment? Your ST segment, still it is not depressed, it's the same. Okay, so no problem with your ST segment. So what are we going to do? What are we going to check is that normally junctional atrial junction only fires 40 to 60 uh, impulses or electrical impulse per minute. But in this case, this is actually a compensatory mechanism as a triggered activity of your autonomic nervous system and by your sympathetic nervous system, signaling the junctional rhythm to compensate due to the lack or to the inability of your SA node to function normally and get a 60 to 100 heart rate. So in order for the heart to generate an impulses or to have a normal heart rate is that there should be compensatory mechanism, and part of that compensatory mechanism is the signal coming from the autonomic nervous system, specifically sympathetic nervous system, signaling the junctional area or the atrial junction to pump more blood, because the atrial junction will now serve as the primary pacemaker of the heart due to the failure of your SA node. So that's why we have this rhythm, and this one is called accelerated. The name of this rhythm is accelerated. Okay, accelerated junctional rhythm. Okay, okay. It's accelerated junctional rhythm. Why is it called accelerated junctional rhythm? Because the normal junctional rhythm is only 40 to 60, but due to um, irritation, and also with the help of the autonomic nervous system that sends signals to the heart, specifically the sympathetic nervous system, signaling the heart to pump more blood, and also to compensate for the lost heart rate, which is only 40 to 60. For the body to sustain, we'll have to have a heart rate of 60 to 100 as part of the compensatory. Again, it's for the compensatory mechanism. So what will happen with this is that with accelerated junctional rhythm, the patient or the person experiencing this one doesn't feel any problems at all, except that there is a decreased output. Okay, so why is it that there is a decreased output? Now here's the thing with your accelerated junctional rhythm. Okay, as what I have mentioned earlier, also with your junctional rhythm, is that if this is your heart, okay, this is your left atrium, your left ventricle, your right atrium, and then your right ventricle. Normally, guys, 75% of the blood will just flow passively to the tricuspid valve, filling the right ventricle. So the 25% of the blood returning from the body will stay in the right atrium. Considering that this is now the impulses coming now from this is your AV node, from the area surrounding the AV node, which is your atrial junction. So there is a possibility that the atrium will not contract, but only the ventricles will contract. Meaning every time your heart pumps blood, the ventricles pumps blood, there's only 75% of the cardiac output being pumped into the lungs, while this 75% as it returns to the pulmonary veins going to the left atrium, automatically, guys, out of 75%, 90% of the 70 of the total oxygenated blood will be uh, will be pushed, or will return to the left ventricle only. So meaning, guys, there is a lesser cardiac output or lesser oxygenated blood that will be pumped throughout the body. So with this, your patient may experience dizziness, your patient may experience syncope. Okay, so there will be some more problems. Your patient will have, due to decreased cardiac output, there will be hemodynamic instability. Your patient may also experience hypotension and any other CNS symptoms, just like your mental changes. Okay, mental changes, yes. So you need to take note of that, because that will those signs and symptoms, you should be managing it palliatively. Okay, especially with the junctional arrhythmias, and also with this rhythm, which is accelerated junctional. Okay, so the more your heart pumps a lot of blood, which is part of compensatory mechanism. Okay, since uh, there is no atrial contraction, then the more that your ventricles will pump the blood, the lesser the cardiac output. Okay, so take note of this, because on the next rhythm, we're going to discuss the other form of your junctional arrhythmias, which requires which requires at least medication and any other therapies that we can help the patient with. Okay, so again, your junctional arrhythmias is represented by an inverted P wave or the absence of P wave. Okay, so next rhythm is this one. As you can check, this is a very fast rhythm. So let's check the heart rate of your patient. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So the heart rate of your patient for this is 180. 180, and that's actually beyond normal heart rate, which is 60 to 100, considering that with junctional rhythm it is no longer the SA node that fires and impulses, but instead it's the atria or the atrial junction that fires and impulses, which is the normal firing rate is only 40 to 60. So meaning this one is considered as a tachycardia. And since it does not come from the SA node, meaning we have a junctional tachycardia because the impulses from this comes from the atrial junction. So we call this one as junctional tachycardia as it exceeds more than 100 impulses, or I mean the heart rate exceeds more than 100. So that is now what we call as junctional tachycardia. So again, P wave is absent and we cannot determine PR interval, but then the QRS complex, as you can see, it is widened. Okay, there is a widened QRS complex, and this one, guys, here at the top, this signifies bundle branch block. So meaning there is also a blockage in your bundle of His. So if the blockage occurs within the bundle of His, we call that as infranodal blockage, okay, or infranodal block. So meaning that block also appears on the bundle of His itself. Okay, so the bundle branch blockage or bundle branch block are discussed on a separate um, topic or a separate course. But then just to give you an overview, this is an example of your left bundle branch block. Okay, and then the other one, this one, guys, is your left bundle branch block. If you can see a QRS complex that looks like this is a significant or the hallmark of your left bundle branch block. But if you're going to see a rhythm that looks like this, so this one, guys, is a significant hallmark of your right bundle branch block, wherein there are two R waves. Okay, so just in case, this is just a side topic, so this will be discussed on a separate ECG course. Okay, so with this, as I have said earlier, that the more your heart pumps, the more the the atrial junction fires and impulses here. Since there is no more SA node that fires and impulses because there's a failure of your SA node to be cut as the primary pacemaker, then it is the surrounding tissue of your AV node that fires and impulses directly going to the ventricles. So meaning, guys, there is no atrial contraction also, then the more that there is a tachycardia, the lesser the cardiac output, and then your patient is very prone to syncope and also prone to hemodynamic instability. So this one requires treatment, and most of the physician will treat this one with your adenosine. Okay, it is treated with adenosine. Okay, so for the dosage, there's a titrating dose, or most of the time they just follow the dosing that is the same with your atrial tachycardia. Okay, so nursing intervention is um, continue monitoring the patient, provide oxygenation if needed, and if there is chest pain, inform the physician so that an appropriate medication will be given, and also assist the patient to whatever um, he or she needs, especially there's a very low cardiac output, so there could be dizziness or syncope. Just um, prioritize the safety of your patient. Okay, so I think that is all for the junctional rhythm. Okay, so let's proceed. So there's only one question for the junctional rhythm. Hope that we are able to discuss this. So what is the hallmark characteristic of a junctional rhythm? Yes, I keep on mentioning this to you. So I think you can answer this one about the P wave. So just specify about the hallmark characteristic, about the P wave itself, and also the heart rate, so that you will know if it's a junctional rhythm or if the impulses comes from the atrial junction, which results to junctional rhythms, or through from SA node, which is normally 60 to 100, and also what's the heart rate if it is a junctional rhythm, and also what will happen to the P wave if it's a junctional rhythm. So those are the hallmark characteristic of this rhythm. Okay, so thank you so much. Take note of this question and send your answers to the email being provided to you. Okay, thank you and God bless.